So I'm pleased to introduce our next speaker, Swati Gaur, who is a geriatrician and medical director of several nursing homes in the Atlanta metro area. And she's chair of the Infections Advisory Committee with the Society for Post-Acute and Long-Term Care Medicine, or AMDA. And she's also on a COVID task force for AMDA. And she's going to talk about some of the practical issues of using these therapies in long-term care facilities and nursing homes. Swati, over to you.
Hey, thanks for that introduction. I'm actually in Northeast Georgia, Gainesville. So I just want to share with you the story of our nursing home with the latest outbreak that we had around 10-ish or so. We found ourselves with 30 patients who were COVID positive. This is our second wave. This was after we had not had any positive patients for a few months. We had about 30 patients who were positive, like I said. Our first patient who received monoclonal antibody was a 72-year-old, multiple medical problems, as you would expect in a long-term care facility: diabetes, hypertension, CKD, BMI of 45 to 50%. 45 to 50 rather, poor function, tested on 12/11, developed cough, shortness of breath, actually was transferred to the ED, received the monoclonal antibody in the ED. And such was our spread of patients. So out of those 30 patients, we identified six additional patients who received monoclonal antibodies, as well as two more patients who we identified. However, they refused the monoclonal antibody after the discussion that we had with them. I do want to just quickly go over the outcomes. The two patients who received the monoclonal antibodies were essentially the ones whose family said they would rather get the vaccine, because we were also coming up against starting to give the vaccine out. One person out of those 7 people was discharged and subsequently readmitted to the hospital and was treated for pneumonia. 3 out of those 7 people were out of the COVID unit on day 11. The 2 people who refused the monoclonal antibodies for vaccine consideration also were discharged from the COVID unit to the regular units on day 11. 2 patients out of those 7 patients did subsequently receive high-dose steroids. 1 is still currently in our COVID unit. And the other one has been discharged to the regular unit as well. Most of our patients had indication of fever, cough, shortness of breath, mild decrease in oxygen saturation, not significant. So our patients ranged from the youngest patient was 62 years of age. Our oldest patient was 98 years of age, who were under the consideration. So essentially, that's the story of our nursing home. We are currently talking to a patient who has multiple medical problems and has developed fever to receive monoclonal antibody. That patient is currently trying to make up their mind about this. Again, due to vaccine consideration as well. They do want to receive the vaccine, and they are hesitant to take the monoclonal antibody and would like to consider it with their family, which one should they prefer to have. That being said, there are a lot of morals to the story. I will just walk you through our decision-making process in long-term care. One of the things that I would say as the chair of Infection Advisory Committee is we do have a toolkit out on the AMDA website. If anyone is wanting to set this up in your long-term care facility, it has a brick and mortar approach, very much so This is the staffing that you need. These are the people that you need to coordinate with, etc. I think, Christian, you had mentioned right before we had started talking, is the fact that NIH currently does not endorse, nor does it disendorse this monoclonal antibody treatment. And the BLAZE-1 trial shows in our subset of population, which is over 65 years of age, especially with multiple comorbidities that we are dealing with in long-term care, our subset of population over 65 years of age, there is an admission advantage. That means our patients may have less number of patients with monoclonal antibodies were admitted to the hospital, with 4% versus 15%. And I think that's what Bill's data shows as well. There's that hospitalization benefit, and then there is a symptom score benefit that we saw. As a medical director in my facility, when we had 30 patients who tested positive and our COVID unit was about full, and we had made extra place for creating a new unit, our hospital itself was overwhelmed with community cases, which is the case in most parts of the country currently. So while I would love to see more data on the monoclonal antibodies, we decided to use monoclonal antibodies because of that hospitalization advantage. Because our hospital system could not, we wanted to keep the patients within our nursing home if at all possible. And that is the benefit that we were looking for. So that's why we went with it. We did set up the logistics to provide monoclonal antibody within our long-term care facility. The logistics, the primary two people that you need to have great coordination with is pharmacy and nursing. We had set up a common area for our patients where patients can go in, have in a big room, which, right now the nursing homes actually are in position to have common areas because the gyms where occupational and physical therapy gyms that were being used before are not being used currently. So nursing homes can actually find these common areas where patients can be wheeled in, and having staffing ratios of about 1 nurse to 6 patients, or 1 nurse and a CNA to 12 patients. One disadvantage of being in a nursing home is your patients come as batches, but the advantage is that you can give monoclonal antibody as batches as well. So we made sure that we have an emergency box available on site, which did have medications for anaphylaxis, etc. Although Bill's data does show that the side effects were not seen, or very minimal side effects were seen. And basically, we had that available, the logistics available. Unfortunately, we had staffing shortages, and we didn't have nurses available. We had about 30% of our staff out with COVID during that time. So our next best thing, what we did is we coordinated with our emergency department, and they had a tent set up where we identified our patients. We did the eligibility criteria, exclusion criteria, got the consents, the FDA fact sheets were given to the patients. We had that conversation, and then sent our patients en masse to this tent where they received monoclonal antibody, an hour of monitoring, and they were brought back within the facility. And this speaks to the coordination that you may need, with the local hospitals as well. Our vaccine consideration, of course, the 4 residents who did receive monoclonal antibodies and are still with us and have not been discharged, are still awaiting that vaccine, and they are deferred for 90 days, and they will be receiving their vaccine in March. The 2 who refused the monoclonal antibody have received the vaccine right as they were considered non-contagious. They were able to get the vaccine. The other consideration is that assisted living facilities, when they have a question about giving monoclonal antibodies, several home care agencies or infusion agencies may be able to give this on site as well. And a lot of nursing homes are taking advantage of that as well. So I just wanted to present our case scenario to you all, and talk about the different considerations that we have had to have.
Thank you, Swati. That was a great overview. And I especially liked how you kind of went through your thinking about full hospitals, limited evidence. Let's just go ahead and do it, because I think that's on a lot of people's minds. I see a lot of questions in the Q&A and chat about when is more evidence going to come, but you really, told us basically we need something right now to try to keep people out of the hospital. We have time for just a question or two. I want to try to get into your thinking about how long you think you're going to focus on monoclonals until the seniors in your long-term care facilities will be eligible for vaccines. Is this just for like a 1-month project, do you think, or do you see it being longer term?
No, I believe, Christian, that the same thought process that we have had, with the paucity of data that we have available right now, I think my consideration is still going to be how bad the situation at the hospitals are. We obviously have a lot of conversations with the families about their goals of care. A lot of this is driven as well by the goals of care, and the families say, we don't want to go to the hospital. What do we have currently available that we should be able to offer to the patients? I did forget to mention, actually, we have had a massive vaccination effort, and barring about 17 or 18 patients, we have vaccinated every single patient who is eligible for vaccination. So they have received their first dose of vaccine in the nursing facilities. The other fact that I wanted to mention is we are somewhat different. We have a hospital-based vaccination effort. So we are able to get vaccines piecemeal, 10 one vial at a time or 2 vials at a time. A lot of nursing homes do not have that luxury. They have the Walgreens and CVS truck coming in for 3 episodes. And when that happens, then that consideration becomes even more, because now you're really trying to time that monoclonal antibody and when the vaccine truck is going to come. And that discussion becomes even more important with the family members or the residents.
Great. Maybe one additional quick question for you is just how have the discussions been going in terms of explaining the difference between monoclonals and vaccines to your patients? I imagine some of them might have dementia. These might be difficult conversations to have. Has that been a major barrier for you?
No, when we have people who do not have capacity to make decision, we do talk to their families. We are currently, the current resident that we have who is eligible for monoclonal antibody and is not sure. We are talking to the whole family about that. We are very clearly talking with the hospitalization advantage that we are seeing in the Blaze 1 study, and talking about that 90-day deferment of that vaccine, the first dose of vaccine.
Great. Well, thank you so much. I hope you stay on to answer questions. There's plenty of them coming up through the Q&A, but